Good morning. Today we are focusing on stroke. In recent developments in acute stroke care, there has been a notable shift from the traditional classification of strokes as either minor or major, based primarily on the National Institutes of Health Stroke Scale, or NIHSS. The focus now centers on a more functional and patient-centered approach that distinguishes between disabling and non-disabling strokes. This change aims to align clinical management decisions with the actual impact on patients' lives, their values, and their recovery goals. The first critical decision in stroke management is to differentiate between disabling and non-disabling strokes. This distinction highlights the functional consequences of the stroke, particularly in key areas such as speech, hand use, vision, ambulation, dominance, and consciousness. It is essential to assess the patient's premorbid baseline, which includes their independence, cognitive status, occupation, and living situation. By understanding these factors, healthcare providers can personalize their approach to treatment, ensuring it is relevant to the patient's unique circumstances. Early discussions about goals of care are vital. Healthcare providers should engage patients or their substitute decision makers by asking questions such as, "What matters most to you?" and "What level of recovery would be meaningful for you?" These conversations help clarify the patient's priorities and guide treatment decisions. There are several time-sensitive treatments available for acute stroke, but it is important to recognize that these interventions carry significant risks. For example, intravenous thrombosis has a 3 to 5% chance of resulting in symptomatic intracerebral hemorrhage. Therefore, transparency in discussing these risks is essential. Providers should ask patients if they find these risks acceptable in an effort to preserve vital functions, such as speech, hand function, or independent ambulation. Identifying disabling strokes involves recognizing specific clinical features that indicate significant functional impairment. Major aphasia, or loss of communication, dense weakness of the dominant hand, dense visual field loss or cortical blindness, prior independent ambulation, and a high functional demand job or lifestyle are all indicators that suggest a stroke may be disabling. When making clinical decisions, it is important to focus on meaningful functions and the values of the patient rather than relying solely on numerical scales. Additionally, healthcare providers should not assume that a low NIHSS score, such as less than 5, indicates a benign stroke. Many patients with low scores may still experience disabling outcomes and should be considered for time-sensitive reperfusion therapies. Finally, aligning treatment planning early with the patient's baseline function and goals can prevent unnecessary or inappropriate interventions. This approach not only enhances clinical outcomes, but also respects the values and preferences of patients, leading to better overall care experiences. In summary, the transition to a focus on disabling versus non-disabling strokes represents an important advancement in acute stroke care, emphasizing the need for patient-centered decision-making in clinical practice.